All right, go ahead and get started. Thanks everyone for being here. It's my pleasure to go ahead and introduce today's speaker. Dr. Neal Chatterjee is an assistant professor of medicine and cardiac electrophysiology at the University of Washington. He's originally from Raleigh, North Carolina, and notes that he has been and continues to be a lifelong Tar Heel fan. Completed his undergraduate education at Princeton University with a degree in molecular biology before attending Harvard Medical School, where he went on to complete medical residency, general cardiology fellowship, and electrophysiology fellowship at MGH in Boston. Also completing a master's of science in epidemiology at the Harvard School of Public Health with a focus on risk modeling. We're grateful that he moved here to Seattle in 2019 with his wife and 2 children to join the faculty in the Division of Cardiology. Clinically, he's had a focus on catheter ablation of cardiac arrhythmias, in particular VT, atrial fibrillation, and other SVTs. His research interests are broadly focused on the prevention and treatment of sudden cardiac death, which he's here to tell us about today. He's interested in application of traditional epidemiology, as well as novel statistical approaches and the use of both invasive and non-invasive measures of risk in addressing sudden cardiac death. His innovative work has resulted in over 60 publications, including 37 original research papers. Neal, we're delighted to have you here today as our speaker. Teach us more about your exciting work. Please, to the audience, feel free to write any questions that arise in the chat box, and both of us will be looking at this, and we'll loop back in for a Q&A at the end of the presentation today. Feel free to go ahead and get started.
Fantastic, Johnny. Thank you so much. Thank you to you and the rest of the Grand Rounds Planning Committee for the invitation today. It's truly a treat and a privilege to be able to join all of you via Zoom. Hopefully in time, I'll be able to join all of you in person. Absolutely delighted to be here. It's been an incredible short time here on the faculty. I think moving to a new city, starting a new job, starting in a new environment in the midst of a pandemic has had its challenges, but it has been a privilege to be a part of this team and this group and this health system, and I've just been truly honored to see all the ways, sort of the truly aspirational ways in which all of us have sort of risen to the occasion to care for patients in these challenging times. With that said, I'd like to move on to talk some more about the topic of sort of sudden cardiac death, which is a topic that is near and dear to my heart, no pun intended. And I'd like for us to think together about our current contemporary paradigms in terms of how we think about the prediction and the prevention of sudden death. And in doing so, I'm hoping to share with you some of the work that we're doing that might be able to update and improve our ability to predict and prevent this. Just by way of disclosures shown here, none of the disclosures noted here are pertinent to the content of this talk. So just by way of outline, I try to organize this talk into 3 parts. Part 1, really emphasizing and focusing on where we are today. What are our current contemporary approaches to the prediction and prevention of risk? Part 2 is going to be talking about this idea of competing risk, and I want to share with you some concepts in competing risk in the context of 2 stories. And then part 3 of the talk is going to move to cover some novel approaches that my group and groups around the world have been employing to update and improve our capacity to predict and prevent the probability of sudden death. So sudden cardiac death, as many of you know, is a major public health challenge. The annual rates of sudden death in the United States approach nearly 300,000 persons per year. And it's estimated that approximately 15 to 20% of global mortality is a consequence of cardiac arrest. One of the major challenges of preventing and treating and actually attenuating the public health burden of sudden death is that sudden death is the first manifestation of cardiovascular disease in almost 40% of patients. So for nearly half of patients who are experiencing a cardiac arrest, before that cardiac arrest, they have no known cardiovascular history. And so how might we, as a public health institution, think about identifying and sort of picking out those patients who have no known cardiovascular disease, who are, of course, at risk for a highly morbid and often fatal cardiac arrest event? In the Western world, coronary artery disease is the most common underlying substrate. And so there's been a lot of interest from my group and more broadly, of course, in looking at patients with established coronary disease or folks at high risk for coronary artery disease, in terms of targeting that subgroup as folks who we might start to think about identifying folks at risk for having a cardiac arrest. We know, of course, that there are high-risk subgroups. So shown here in this graphic from Bob Meyerberg, we know that patients who have a low ejection fraction, patients with advanced heart failure, patients with a prior history of cardiac arrest, we know that those patients are at high risk for having a cardiac event. And a lot of those characteristics serve as the basis for our guidelines for who does or does not qualify for something like an ICD. However, if you look on an absolute scale, these high-risk subgroups and these high-risk patients only account for a small proportion or minority of the total number of cardiac arrest events happening around the world. Conversely, the majority of cardiac arrest events around the world are happening in patients and in populations in whom there's no consensus on prediction or prevention. And so this is really the sort of core driving force behind the work that my group does, is trying to think trying to think expansively about how we might be able to improve prevention and prediction in this large population. If you look at the general population, the absolute risk of having a cardiac arrest is very, very low. It's approximately 0.01 to 0.03% per year. So if you imagined a risk marker that, say, sort of doubled the risk of having an event, it's very unlikely that an isolated risk marker is going to take somebody in the general population and push their risk up high enough where we would then start to be justified in offering a patient like that something like an ICD. So instead, where a lot of, I think, sort of attention is being placed appropriately are patients who are somewhere sort of between the general population and high risk. So patients who are sort of at moderate risk, in whom we might start to think about the role of risk enrichment as a strategy to justify cardiac prevention. And so I thought with that outline, we would then now move to talk some more in part one of this talk about where we are today in terms of risk stratification. And to do that, I thought we would start by evaluating some of the risk tools that we use all the time at the bedside. So for example, the CHADS-VAS score is a very commonly used score that we use at the bedside in patients with a history of AFib, for example, to decide who does or does not qualify for anticoagulation therapy. The CHADS-VAS score, as sort of many of you know, is comprised of a variety of variables, many of which are dichotomized as the presence or absence of a risk marker. And if you have a high enough CHADS-VAS score, the guidelines would advise that we start those patients on anticoagulation to prevent a stroke. There are other risk scores in our world, for example, the hypertrophic cardiomyopathy risk calculator, which uses a variety of inputs. This risk calculator is sponsored by the European Society of Cardiology, can be found online for free. And so if you're seeing a patient in the office with hypertrophic cardiomyopathy, you can implant these risk inputs, and the risk score spits out your absolute risk of having a sudden cardiac death at 5 years. And if your absolute risk is greater than 5% at 5 years, the guidelines would advise that we implant an ICD in a patient like that. And finally, it would be hard to give a talk at this institution talking about risk scores and not at least acknowledge the Seattle heart failure model, which, as many of you know, is used around the world. And it's a sort of relatively complex model that has a lot of inputs, but it's a way in which we're able to quantify the absolute total mortality risk in our patients with heart failure. And so I would offer to all of you that all of these risk scores have three sort of basic characteristics. The first characteristic is dichotomization, both of the risk markers themselves and also for the treatment threshold. So in the case of the CHADS-VAS score, most of the components of that CHADS-VAS score asks a yes or no question. Does this patient have diabetes, yes or no? And in the case of the hypertrophic cardiomyopathy score, the treatment threshold is also risk-based and also dichotomized. Is that risk higher than 5%? If yes, then proceed to an ICD. If it's less than 5%, then the patient does not qualify for an ICD. The other characteristic of all these risk scores is that we are deploying them in real time at the bedside. And so we're evaluating risk at a moment in time. And perhaps we see a patient once a year. And so of course we are sort of updating our priors as we're seeing patients over time. But the sort of real world sort of reality of deploying risk tools is that we are doing so using the information present at the time of the risk tool application. And then the final characteristic of these risk scores is that all of them are uniformly a function of the absolute risk of some sort of an event. So in the case of the CHADS VAS score, your absolute risk of stroke. In the case of the hypertrophic cardiomyopathy calculator, your absolute risk of having a sudden cardiac death. And so I wanted us to apply those characteristics in the context of sort of thinking about whether or not this paradigm serves us well in the prediction and prevention of sudden cardiac death. So in terms of dichotomization, we know that biological risk doesn't usually exist as a dichotomous function. So here are data that I'm showing you that we published in JAMA a few years ago, looking at the relationship between left ventricular ejection fraction and the risk of having a sudden cardiac death. And we looked at a population of patients, approximately 6,000 patients who had coronary artery disease and relatively preserved heart function. And if you start at an ejection fraction of 60%, you see clearly that as you go down the ejection fraction spectrum, there is a continuous sort of association between a lower left ventricular ejection fraction and a higher risk of dying of a sudden cardiac death. And so even though our current guidelines dichotomize left ventricular ejection fraction as a way to qualify patients for things like an ICD, we know that our most sort of commonly used risk marker doesn't really have that sort of biological property. The other challenge, of course, is that the same risk marker might actually work very well as a dichotomized risk marker for some patients and not for others. So here I'm showing you data from patients with non-ischemic cardiomyopathy. And the authors were interested in looking at whether or not the presence of scar in the heart was a way to predict an adverse cardiac event. And here they find that the presence of scar as compared to the absence of scar seemed to be a pretty darn good way to be able to delineate who is at high risk for a cardiac event or not. And to these authors' credit, if you look at the paper carefully, they did investigate whether or not there was a dose-response relationship, and in fact, they could not find one. And so in this instance, for patients with non-ischemic cardiomyopathy, the presence or absence of scar might actually serve as a great tool, a great dichotomous tool to predict who's at risk for having an adverse event. Of course, however, that story is not always the same in sort of other patients. So for example, if you look at the same exposure, the same concepts of scar in the ventricle, and you look at the relationship between scar in the ventricle and the risk of an adverse cardiac event, now in patients with hypertrophic cardiomyopathy, you see that the risk is probably not dichotomous. In fact, it's curvilinear, and it seems to really inflect at around a scar burden of 20%. So here, one of the challenges is that even when you find a risk marker, it might operate optimally as a dichotomous marker in some patients, but not sort of in other populations of patients. So what about this concept of cross-sectional assessment? We've known for a long time that the risk of having a sudden cardiac death is dynamic. This was shown very nicely by Scott Solomon and colleagues at the Brigham several years ago. Scott and his colleagues asked a very straightforward question, which is to say, after a myocardial infarction, what is the risk of dying of a sudden cardiac death? They happen to stratify their population by left ventricular ejection fraction, but regardless of what line you follow, you clearly see that there's a higher risk of sudden cardiac death in the first 3 to 6 months after myocardial infarction. And once you get out to about a year, that risk seems to approach a low and basal state. We also see the same sort of thing in patients who have an ICD. So if you look at the relationship and the time in between ICD treatments, if there was an equal spacing of time between having an ICD therapy, you would expect a line that looks like this dashed line. What instead you see is a line that looks like this solid line, which really emphasizes that ICD therapies in our patients who have defibrillators are clustered. So clearly the risk of having a sudden cardiac death is dynamic, it's clustered. And so how do we think about capturing that dynamism when we're evaluating patients? And finally, what about this concept of absolute risk? So here I'm showing you data from a whole host of randomized controlled trials in heart failure patients that have a low left ventricular ejection fraction. And I'm showing you the annualized mortality, total mortality in gray, cardiovascular mortality in blue, and sudden cardiac death mortality in red. And one of the things you'll appreciate is that over time, we've gotten better at taking care of patients with heart failure, so that sort of newer trials have lower rates of all types of mortality as compared to older trials. The other thing that folks have taken account of in sort of looking at these trials is that if you look at ICD trials associated with a survival benefit, all of them seem to have an absolute risk of sudden death of more than 3% per year. And so for the better part of more than 20 years, there's been this incredible push in the community to find subgroups in the general population or in populations who don't currently qualify for things like an ICD, and ask the question, is there something magical about this 3% per year threshold? Can we identify subgroups of patients using risk markers that have a greater than 3% per year risk of sudden death? And then if we apply an ICD to that population, we might then be able to extend or improve the quantity or survival for that subgroup. We know, however, that that's not true. So after Scott published that paper in the New England Journal showing that folks are more likely to die of sudden death after a myocardial infarction, there was a huge rush to test and evaluate the role of ICD implantation in that exact context. And so I'm showing you data here from the IRIS study, which was a randomized trial of ICD implantation early after myocardial infarction. And indeed, if you look at the control group of that study, the annual rates of sudden cardiac death were exactly at that magical threshold of 3% per year. And indeed, if you looked at the impact of the ICD worked. It cut the rates of sudden death in half. But the major takeaway of the IRIS study is shown here, which is to say that the ICD had no impact on overall survival. So here you have a therapy applied to a population that has a reasonable absolute rate of sudden death, but is doing nothing to actually improve the overall survival for that population. And the major reason for this discrepancy or this discordance, of course, has to do with the concept of competing risk, which I'll share with you more about in part 2 of this talk. But to close out part 1 of this talk, if we sort of think about these 3 sort of foundational characteristics of risk scores, dichotomization, cross-sectional assessment, and absolute risk, we see that if we apply that paradigm to the concept of sort of sudden cardiac death, from a dichotomization standpoint, we appreciate that a lot of our risk markers are existing on a biological continuum and perhaps should not be dichotomized. We also see that the same risk marker might be best dichotomized for some patients, but not for others. In terms of cross-sectional assessment, like we talked about, we've known for a long time that the risk of sudden death is clustered and dynamic. So how might we think about strategies that better capture that type of dynamism? And finally, from an absolute risk perspective, I don't mean to suggest to you that absolute risk does not matter. Absolute risk absolutely matters, but I would invite us to think carefully about what type of absolute risk matters. Is it the absolute risk of sudden death? Is it the absolute risk of total mortality? And part of that concept, of course, is closely tied to this notion of competing risk, which then serves as a segue to part 2 of the talk. So I'd like to share with you some ideas and concepts in competing risk, and I want to do so in the context of 2 stories. The first story is titled "Competing Risk is Hard to Get Away From," and the second story is titled "Higher is Not Always Better." So we've known for a long, long time that patients at risk for sudden cardiac death are also at risk of competing modes of death. And for all of us that see patients in the real world, there are real sort of clinical consequences of competing risk as it pertains to patients at risk for sudden death. It means, for example, that the majority of our patients who undergo ICD implantation will never actually get shocked by their ICD. There was a paper a few years ago which sort of received a lot of appropriate attention that pointed out that more than half of older patients who underwent ICD implantation had either died or were enrolled in hospice programs in 5 years after their ICD implant. So clearly, in contemporary practice, with application of contemporary guidelines, we can do a better job of identifying who really stands to benefit from our preventative sort of strategies. And the implications of competing risk also vary by stakeholder. So if you're a clinical trialist, competing risk means that you potentially perform and fund and execute an ICD trial that lowers your risk of sudden death, but has no impact on overall survival. We saw a high-profile example of that in terms of the IRIS study. We saw the same thing in the Dynamite study, the same thing in the Danish trial. Lots of high-profile examples of ICD trials that reduce the risk of sudden death, but do nothing for overall survival. If you're a patient, competing risk means you undergo an invasive procedure that has risks attached to it. You now have leads in a device in your body that have longitudinal risk, and you're exposing yourself to all of these risks to have a therapy that is very unlikely to actually extend the quantity of your life. And if you're a healthcare system, it means investing lots of money in a invasive and expensive therapy that has longitudinal sort of consequences that may or may not actually be improving the quality or quantity of a patient's life. So understanding competing risk matters. And I want to talk to you more about that in the context of these two stories. So the first story is titled "Competing Risk is Hard to Get Away From." And here's a picture of the quarterback of the University of Washington running away, of course, from our feared rivals to the south. So we thought, as opposed to acknowledging that competing risk is present, we thought it might be helpful if we could quantify subtypes of risk. And so here I'm showing you data from a large heart failure trial where we effectively came up with models to predict your absolute risk of dying of a sudden cardiac death, shown here on the y-axis, and also your absolute risk of dying of competing death, shown here on the x-axis. And again, these are data from a heart failure trial of around 6,000 patients. And each of these blue dots is one person. So for this sort of particular person, their probability of dying of, their 4-year probability of dying of sudden cardiac death is around 40%. And their 4-year probability of dying of a competing death is slightly higher than that. The red line here is the line of unity, where your probability of dying of one death type is the same as the probability of dying of the competing death type. And there are two basic things that I want you to take away from this slide. The first thing that you'll observe is that most of these dots are falling sort of below the line of unity, which is another way of saying that for most of our patients that we care for, they're more likely to die of a competing death as opposed to dying of sort of sudden cardiac death, right? So that's one of the challenges that we're confronting when we're sort of thinking about preventative strategies. The empiric reality is that the odds are that the patient in front of us is more likely to die from something else as opposed to dying from a sudden cardiac death event. The other thing that you'll appreciate is that these dots are incredibly tightly clustered, right? So you don't need me to tell you that the correlation coefficient happened to be 0.94. You can appreciate that patients at high risk of dying of a sudden death are also at higher risk of dying of competing modes of death. And so if you took this type of sort of schematic and you were thinking about risk stratification, you could imagine 3 types of risk markers. Ideally, you would find a risk marker that has a green-like property, a marker that would take any one of these blue dots and increase the risk of dying of sudden death, but do nothing to your risk of dying of competing death. And so if you could find a green-like marker, you would ideally find a subpopulation of patients in whom you could start to think about strategies for prevention. Conversely, you could imagine a blue-like marker, a marker that increased your probability of competing mortality, but did nothing for the probability of dying of sudden death. And these blue-like markers could serve in theory to disqualify a patient from something like an ICD. And what I'll try to convince you of is that most of what we have today in contemporary practice, in fact, are red-like markers, markers that increase the risk of sudden death, but also increase your risk of competing death. And so push any of these blue dots up the line of unity. And what I'll try to convince you of is that markers that have these red-like properties are not particularly helpful as we think about stratifying for risk in this population. And so we try to look in an explicit way at what types of markers are red-like markers or green-like markers and blue-like markers. And these are data that were published in JAMA a few years ago in a large population of patients who had coronary artery disease and a relatively preserved ejection fraction. And so we looked at a whole range of standard proposed risk factors for sudden cardiac death, including age, sex, race, hypertension, diabetes, AFib, and so forth. And we looked at the relationship of these risk markers with two types of death. We looked at the association of the risk marker with the probability of dying of sudden death, shown in orange, and the association of those risk markers with competing death, shown in blue. The other thing that we did is we performed competing outcome models, which is a fancy way of being able to say, is the association of the risk marker the same or different with one death type as compared to the other? So these p-values that you see here are the p-values for the differential association of the risk marker with one death type as compared to the other. So let's just actually talk about the data. So if you start here at the bottom of the slide, we focused on diabetes and AFib, which have been long reported to be risk markers for the risk of sudden cardiac death. And sure enough, as we expected, patients with diabetes or patients with AFib had almost a twofold increased risk of dying of sudden death. Importantly, though, they also had a twofold increased risk of dying of other kinds of death. And so if you looked at the p-value for the differential association of diabetes or AFib with one death type for the other, as you might expect, clearly null. So in that paradigm, diabetes and AFib are operating as red-like markers, markers that are increasing the probability of dying of sudden death, but also increasing the probability of dying of competing death. And I would argue not particularly helpful as a way to risk stratify patients and targets for cardiac prevention. Conversely, we found age to be a blue-like marker, as you might expect. So as folks got older, much higher risk of dying of competing mortality, modest increased risk of dying of sudden death. And so in this way, older age might serve as a blue-like marker that could, in theory, disqualify patients from something like an ICD, clearly associated with a higher risk of competing mortality as opposed to the risk of sudden death. We then went on to look at left ventricular ejection fraction and heart failure class, the two sort of foundational components of our current guidelines for how we think about risk stratification. And we found that if you looked at the lowest strata of ejection fraction or the most advanced categories of heart failure, there was no question that low EF and advanced heart failure were indeed associated with higher risks of dying of sudden death. But importantly, they were also associated with competing mortality. So the p-value for the differential association here, not significant. And so just like we saw with diabetes and AFib, low ejection fraction and advanced heart failure are red-like markers, markers that increase the probability of both types of death. We started to see intriguing associations at less abnormal sort of levels of left ventricular ejection fraction. So patients with an EF of 40 to 49% had a quadrupling of their risk of sudden cardiac death, only a doubling of risk of competing mortality. And here we start to see perhaps that a low normal ejection fraction might start to operate like a green-like marker, a marker that might be more specific to the risk of sudden death. Conversely, mild heart failure seemed to double the risk of competing death, had no impact on the risk of sort of sudden cardiac death. And so mild heart failure might stand as a blue-like marker. So if we return back to this schematic, most of what we found in contemporary practice, be it diabetes or AFib, advanced heart failure, low ejection fraction, most of our contemporary risk markers are really red-like markers, markers that increase the probability of sudden death, but also increase the probability of competing death, and ultimately not particularly helpful as we think about risk stratification. We did find some blue-like markers, age in particular, and you might imagine that if you had a fancier model to capture things like sort of frailty, that could also serve as a blue-like marker. But what we didn't find, the big gap we didn't find, are green-like markers, markers that increase the probability of dying of sudden death, but no impact on the probability of competing death. And as a teaser, I'll tell you, wait for part 3 of this talk as we think about what those green-like markers might be. But I want to round out part 2 of the talk by telling you another story, which I'm titling here, Higher is Not Always Better. And for fans in the audience of Spinal Tap, you'll appreciate this reference when the band asks for the volume to get dialed up all the way up to 11. And for fans not of Spinal Tap, I'm highlighting here the Space Needle, which is a foundational part of the skyline, of course, here in the city. And as I learned after moving here, is only the 8th tallest building sort of in Seattle. So what does higher is not always better means? So here I'm showing you again that graphic of annualized mortality, again, total mortality in gray, cardiovascular mortality in blue, and sudden death mortality in red, in a whole range of large heart failure trials. The MADE-IT 1 and MADE-IT 2 trials happens to be an ICD trial. CHARM happens to be a drug therapy trial. The details are not important. You'll notice a couple things. Sort of again, over the last 20 plus years, we've gotten better at taking care of patients with heart failure. So overall rates of all kinds of mortality have gone down sort of dramatically over time. So much so that when you start to look at contemporary cardiovascular trials, so the Danish study is an ICD trial that was just performed in non-ischemic cardiomyopathy, predetermined as a prospective observational cohort of patients with coronary disease. The absolute rates of sudden death in those studies are very, very low. And so I would invite us to think again about this magical threshold that's been proposed of 3% per year, right? Folks have gone back and said, well, in MADE-IT 1 and MADE-IT 2 and SCUD-HEFT, I just have to highlight SCUD-HEFT because it was run by Jeannie Poole and Gus Barty here at the University of Washington. But if you go back and look at these randomized trials that showed a survival benefit, all of these trials had the same characteristic. The rates of sudden death in the control group of all these trials was more than 3% per year. And so there's been a lot of intense interest in contemporary practice, particularly among trialists who have asked the question, can we design trials that use some inclusion criteria, some risk marker for inclusion criteria that is able to enrich for the absolute risk of sudden death. And if we can apply that inclusion criteria, we might be able to find a subpopulation of patients in whom, if we apply an ICD, voila, we're able to identify a survival benefit. So the question is, can we design trials that enrich for absolute rates of sudden death to obtain a survival benefit for ICD therapy? And so to think about that a little bit more, I wanted to highlight what we're trying to accomplish when we're designing a cardiovascular outcomes trial. And so what I would emphasize is that there's really 2 primary endpoints in all cardiovascular outcomes trials. I picked a non-EP trial just to stay slightly outside my lane here. So this is a transcatheter mitral valve repair trial. And in this cardiovascular outcomes trial, there's 2 primary endpoints. The first endpoint is the hazard ratio for all-cause mortality. And the second endpoint is the number needed to treat to save 1 life. And if you look at any outcome trial, not even a cardiovascular outcome trial, they all sort of fundamentally have these 2 endpoints. And if you look at those 2 endpoints mathematically, they're really just a function of the rates of death in your control group and the rates of death in your treatment group. And so if you were to apply this to the ICD, and you assumed that there was no impact of the ICD on competing mortality, which I think is a safe assumption, what you find is that the hazard ratio for death is really a function of the proportional risk of sudden death, whereas the number needed to treat to save a life mathematically is only a function of absolute risk. And so what I want us to start to appreciate is that when we're thinking about designing clinical trials and when we're thinking about what our goals are, the endpoints that we care about may be contingent or may be a function of two totally separate concepts. And so I want to expand upon that over the next few slides. So as I mentioned at the outset of the talk, we know that there are patients who are at very high risk for sudden cardiac death, folks who've had a prior cardiac arrest, folks who have a very low ejection fraction. For those folks, we implant an ICD, and we know that the ICD can improve survival. There are also folks in the general population whose absolute rates of sudden death are incredibly low. And so in that population, we would sort of generally have a very high bar about applying something like an ICD to that population. And that, of course, leaves us with everybody else. And a subgroup of particular interest are patients who have coronary artery disease, but have left ventricular ejection fractions that don't otherwise qualify them for something like an ICD. So an ejection fraction of greater than sort of 30 or 35%. And so we designed and executed a prospective observational cohort study in thousands of patients with coronary disease and relatively preserved ejection fractions to be able to think about risk stratification in that particular group. And so I'm showing you data here from that work published in JAMA a few years ago. And we asked the question, what if we used left ventricular ejection fraction as a way to stratify this group of patients with coronary disease? And sure enough, if you looked at absolute rates of sudden death across strata of ejection fraction, we see here that ejection fraction does a pretty good job of stratifying risk. There's a 5-fold gradient of risk if you look across the ejection fraction spectrum. What most papers won't tell you and show you is what's happening to competing mortality. So it turns out that while ejection fraction is a pretty good way to stratify for the risk of sudden death, it's also a really good way to stratify for the risk of competing mortality. And so now if you looked at proportional risk, so inside of each strata of ejection fraction, what proportion of deaths are sort of sudden cardiac death, you find that as you go down the ejection fraction spectrum, there's really no change in the proportional risk of sudden death, regardless of what strata that you're examining. And so going back to that concept of sort of sudden death and competing risk being hard to get away from, what you find is that the correlation of the risk of sudden death and the risk of competing death uncouples these ideas of absolute and proportional risk. So what does that mean if you were going to be designing a clinical trial? So say you wanted to design a clinical trial in patients with coronary artery disease, and you had a variety of subgroups shown here, so stratified by ejection fraction, diabetes status, heart failure status, and you just lined all of these patients up from left to right, lowest absolute risk on the left, highest absolute risk on the right. And you said, if I designed a clinical trial in any of these subgroups, what would I expect the number needed to treat to save one life with an ICD to be? So we modeled that. And as you might expect mathematically, as the absolute risk of sudden death goes up, the number needed to treat to save a life with an ICD goes down. And if you look at those folks with advanced heart failure or a low left ventricular ejection fraction, the estimated number needed to treat to save a life would be 31. You might say, fantastic. Well, what about the other endpoint of all of our cardiovascular outcomes trials, the hazard ratio for overall survival? So we modeled that too. So I'm showing you here on the y-axis the percent reduction in mortality anticipated with an ICD. And here I'm showing you again those same subgroups still organized from left to right, from lowest absolute risk to highest absolute risk. And here you see a mess. There's no association between absolute risk and the expected hazard ratio for overall survival. Conversely, if you start to look at proportional risk, you find that the percent reduction in overall mortality is exquisitely sensitive to proportional risk. And of course, this is not a surprise. It's a mathematical truth that your proportional risk of sudden death is going to be a driver or a primary determinant of your relative risk reduction for overall um, overall reduction in mortality. And so, for example, if you looked at younger patients in this large observational cohort, so folks less than the age sort of a 60, half of their death risk is dying of a sudden cardiac death. And so if you're walking around and of the probability of dying of anything, half of that probability is dying of sudden death, it would make sense that having an ICD could be incredibly impactful. And so if you were designing a trial in younger participants with established coronary artery disease, we would estimate that an ICD would be associated with a 30% reduction in overall sort of mortality. Conversely, if you designed a trial only focused on absolute risk, the expected hazard ratio for overall survival would only be modestly improved. And so to put this all together, from a public health perspective, from a trial design perspective, if you deploy a strategy that is only focused on absolute risk, you'll do a good job of increasing absolute risk for sudden cardiac death. But because of the correlation of death subtypes, you're also going to be inviting a lot of competing risk. And what that will translate into is only a modest impact of something like an ICD on overall survival. Conversely, if you design a public health strategy or a trial strategy focused on proportional risk, you will identify subgroups who I would argue really stand to benefit the most from our preventative strategies. And so with that, I'm going to now move to part 3 of the talk. I am mindful of the time of about 20 minutes to share with you some of the work that our group is doing, trying to move the needle forward in terms of the future of risk prediction and trial design. And I want to touch on 3 broad topics here. The first is improving the specificity of our risk markers. The second is to think creatively about capturing dynamic and transient risk. And the final is to sort of move beyond the current paradigm that is exclusively focused on absolute risk. So how might we improve the specificity of risk markers? I sort of gave you a teaser in part 2 of the talk and, sort of showing you this paradigm of sort of risk stratification and risk markers. And I said, what we would really want to imagine if we had our druthers would be to find risk markers that have these green-like properties that increase the risk of sudden death, but no impact on the risk of competing mortality. And so this is a concept that folks have been thinking about for a long time. Here's a schematic from Jeff Goldberger, who's a friend and colleague from the University of Miami. And Jeff and his group point out that our current approach to risk stratification is shown here on the left. We take a population at risk, we measure their left ventricular function, and basically in a dichotomous fashion say you're high risk and you're low risk only based on your left ventricular ejection fraction. And what Jeff's group and my group and others have really been trying to focus on instead is identifying risk markers that are directly implicated in the causal and biological pathways of the pathogenesis of ventricular arrhythmia. So if you wanted to imagine a risk marker that was specific to a ventricular arrhythmia, I would argue one of the ways to accomplish that is to identify markers that are as close as possible in the causal pathway to the pathogenesis of having a ventricular arrhythmia. And so one of the ways in which you might imagine doing that is identifying those risk pathways and importantly, identify risk pathways that are distinct. And by identifying these distinct risk pathways, use a multimodal approach to then sort of generate a risk score, which could then be used to stratify patients as low, moderate, or high risk. And Jeff points out here that you could imagine doing something like this in a parallel fashion or sort of in a sequential fashion. But the underlying point here is that you want to be able to identify risk markers that are uniquely specific to electrical risk, right? So markers like diabetes and AFib, sure, may play a role for the risk of sudden death, but they're also capturing a lot of risk that are pertinent to competing mortality. So one of the tools that our group thought would be a fantastic way of capturing these domains of risk is the 12-lead EKG. We like the 12-lead EKG because it's easily available, low cost, and easily deployable in multiple settings. So you don't need sort of a fancy scanner. It's something that could be sort of deployed here in Seattle, but also deployed across the world. And so in a large population of patients with coronary disease and relatively preserved ejection fraction, we looked at the association of a range of EKG markers, and we organized them by domains of risk. So we picked markers that captured pathology in the anatomy or structure of the heart. So for example, the presence of Q waves, which might capture the presence of scar, for example. We also found EKG markers and organized them into an sort of autonomic domain of risk. So markers that might capture perturbations of the autonomic nervous system, which could then lead to a higher risk of having a ventricular arrhythmia. And in the same vein, markers of abnormal depolarization and markers of abnormal repolarization. And we looked at the association of these markers with the risk of sudden death. And importantly, in the derivation of these models, we explicitly accounted for the competing risk of other kinds of mortality. And what we found were basically 4 markers, 2 markers that captured anatomic risk, 1 marker that captured depolarization risk, and 1 marker that captured repolarization risk. And we found that these markers were highly and robustly associated with the risk of sudden death, even after you adjusted for a whole range of other standard risk factors and even other EKG risk factors. And we put all of these, we scaled all of those sort of risk associations into a point score, and we generated low, moderate, and high risk categories. And we looked at the rates of sudden death stratified by the EKG risk score in a derivation and validation subset. And we found that in the high risk EKG score population, at 5 years, you started to see absolute rates of sudden death of more than 5% per year, which is exactly the threshold where we currently think about implanting things like an ICD in patients with hypertrophic cardiomyopathy. But you might say, Neal, you just spent 20 minutes talking to me about competing risk. What does your EKG risk score do with respect to the association with one death type as compared to the other? So here we are now looking at the association of our risk score with the risk of sudden death in red and the risk of competing death in blue. And if you focus here on the high risk subgroup, we were pleased to find that the risk score really did seem to be specific to the risk of sudden cardiac death. So almost sort of tripling the risk of sudden death in the derivation and validation cohort, and only modestly sort of associated with the risk of competing mortality. So as a concept, part of what we wanted to accomplish with this paper is by suggesting that explicit incorporation of competing risk into the derivation of your risk score helps you identify risk markers that are specific to the risk of sudden death and not necessarily specific to the risk of competing mortality. So markers that really truly have that green-like property. So putting this all together, we found 4 EKG markers that were capturing sort of distinct domains of pathophysiology that is pertinent to the risk of sudden death. We found that in combination, we could find high-risk patients that had high enough rates of sudden death where you might consider offering those patients something like an ICD. We went on to show that if you look across quartiles of sort of clinically based risk, that the EKG score did a good job of stratifying your risk of sudden death regardless of what your clinical risk was deemed to be. And we then went the next step to actually estimate and model what a clinical trial would look like if you were to use this high-risk EKG score as part of your trial design. So if you designed a clinical trial in which the inclusion criteria was a high-risk EKG score with or without a low normal ejection fraction, we would estimate that you would find that the ICD could reduce overall mortality by more than 20%. And we then performed power calculations to show that you would only need a trial of somewhere between 3,000 to 4,000 people to be able to show this sort of survival benefit. So while the details are not critical, our goal was to be able to emphasize that explicit incorporation of competing risk leads you to find a multimodal risk model that is able to identify absolute rates of sudden death that matter, proportional risk of sudden death that matters, and now can help at least start the conversation of having clinical trials which can be executed and are feasible that would then translate to meaningful survival benefit for patients, in this case, with a history of coronary artery disease. All right, so now moving beyond the EKG, what are some other markers that our group has been examining that are pertinent to the pathophysiology of having a sudden cardiac death? Well, there's been a long-standing appreciation of the role of cardiac inflammation and fibrosis in particular as drivers of risk as it pertains to the risk of ventricular cardiac arrhythmias. And so in close collaboration with colleagues at Mass General, we looked at a range of biomarkers, and in particular sort of microRNAs and their association of microRNAs with the risk of sudden cardiac death. So in a large case control study and data that we published last year in the Journal of the American College of Cardiology, we found that there were 3 particular microRNAs which were each associated with a higher odds of dying of sudden death. And if you looked, if you constructed a microRNA score, patients with abnormal levels of all 3 microRNAs had more than had an approximate 5-fold odds of dying of sudden death. And we then took the next step and actually looked in an ontological pathway analysis and found that those microRNAs seem to be specifically involved in pathways associated with cardiac inflammation and fibrosis. And so those case control data are now serving as the basis for a multi-center prospective biobanking effort in which we are looking specifically at these microRNAs in patients with a history of ventricular arrhythmias in order to hopefully find a way to be able to predict who might be at risk of having a dangerous event in the future. As an extension of this concept, there's also been an expanding interest in the role of the immune system in the homeostasis and pathogenesis of cardiac arrhythmias. I'm showing you here a slide from a review in Nature from a few years ago that highlights the role of cardiac macrophages, which use gap junctions to exert crosstalk with cardiac cells. And the crosstalk between macrophages and cardiomyocytes modifies the transduction of cardiac ions in important ways that actually shift components of the action potential. And so that work has led me to a close collaboration with my colleague in the advanced heart failure section, Dr. Stempian Otero, whose group has had a long-standing interest in the role of cardiac macrophages in patients with heart failure. I'm showing you here data from her group that were published in the Journal of the American College of Cardiology a few years ago, looking at gene expression in cardiac macrophages before and after treatment of patients with heart failure. And you see clearly that in patients who are treated with heart failure, there's a clear shift in expression of pro-fibrotic and pro-inflammatory genes in cardiac macrophages. And so we are currently looking very carefully at the association of these exact macrophage expression profiles, both pro-fibrotic and pro-inflammatory, in an advanced heart failure cohort. And we're looking at the association of those profiles with the risk of cardiac arrhythmias. And the hope, of course, is that this could serve as the basis for targeting these pathways and sort of modulating the immune system as a primary treatment strategy that could serve as an antiarrhythmic. Finally, it'd be hard to leave a talk like this and not at least acknowledge the role of genes. And I'm showing you here data from a couple of different cohorts. On the left, data from a former co-fellow and good friend of mine, Amit Kara, in which they looked at the general population and found pathogenic variants in almost 1% of the general population that were associated with an increased risk of adverse cardiac events. And these gene variants were sort of implicated in pathways associated with cardiomyopathy, with coronary artery disease, with long QT syndrome, and even in some cases, things like abnormal aortic syndromes. And so this is, I think, starting to tell a story that in the general population, we might be able to pick out gene variants associated broadly with pathophysiology that could then go on to lead to sudden death. And we might start to think about the role of things like polygenic risk scores that could be used to identify patients at high risk of having a sudden death event. I'm showing you here on the right very elegant data from Dr. Sotu Denia, who's a member of our section here, and her group looked at gene variants that were associated with a range of risk factors, including BMI, in some cases things like QT interval, QRS duration, heart rate, blood pressure, and they looked very carefully to see if gene variants associated with any of those risk markers were then associated with the risk of sudden death. And her group found that gene variants implicated in things like the QT interval and atrial fibrillation did seem to be associated with a higher risk of sudden death in the general population. So again, I think there seems to be a clear role for identifying, sort of genetic risk. And I think particularly in this new era of polygenic risk scores in which we're able to collate risk across the entire genome, you might start to imagine that if you can collate risk across sort of enough SNPs or enough parts of the genome, you might start to identify risk thresholds where you could use that sort of risk score to qualify a patient for something like an ICD. Finally, I'll mention here that there's been some exciting work in the bioengineering field, in particular the group at Johns Hopkins led by Natalia Troyanova, which has been using computational modeling as well as cardiac imaging to identify patients who might be at higher risk for things like sudden death. Because the hour is short, I'm going to move on to talking about a few other topics here. One is capturing dynamic and transient risk. As we talked about at the outset of the talk, we know that the risk of sudden death is dynamic. We highlighted the fact that for example, post-myocardial infarction, there appears to be a window of time where the risk is much higher as compared to, say, for example, a year out. And so from a public health perspective, you might imagine trying to identify sort of particular events or sort of particular exposures in the lifetime of your patient that were associated with transients of risk. So for example, after myocardial infarction or after, for example, a heart failure hospitalization, and you might then say, well, this patient is at risk of having a high risk event in the next 3 months. Might we offer them transient protection? So for example, have them wear something like a wearable cardiac sort of defibrillator. You protect the patient for that short period of time, and then after their risk comes back down to their low and basal state, they no longer need that sort of protection. So we were interested in that concept and looked at this idea as it pertained to a heart failure hospitalization. As sort of many of you know, in caring for patients with heart failure, the time right after heart failure hospitalization appears to be a particularly high risk time, a high risk time for folks to come back with more heart failure, a high risk time for folks to come back to the office and not do well. And so we were interested in looking at death subtypes after heart failure hospitalization in patients with a low ejection fraction. And these are data that are currently in preparation. And in fact, we do see that there does seem to be a dynamism of risk. So time zero here is the date of a patient going home from their heart failure hospitalization. And it does seem that over the first 3 or so months after that hospitalization, patients are at higher risk of a heart failure death and also at higher risk of a sudden cardiac death. We also looked at other death types as a sort of negative control and found that there was no association there. And so I think this is the beginning of a conversation of using this sort of exposure-based approach where we can identify transients of risk where transient protective strategies might actually matter. The story, of course, is not so simple. We did the same sort of thing in a population of patients with heart failure and a normal ejection fraction. And in this population, we really found that it was competing mortality that dominated the risk of death after a patient went home from a heart failure hospitalization. So it's clear that this strategy in isolation is not going to be enough to identify transients of risk. For the sake of time, I'm going to skip over this slide, which is a novel way to think about looking at continuous measures inside of a clinical trial. But suffice to say, these are data that are currently in press, and we're currently writing a commentary on this paper. But there are groups out there who are finding smart ways to look at the trajectory of biomarkers before a patient dies. So what's happening in this case to to the NT-proBNP, what's happening in this case to a patient's potassium in the months, weeks, days, and hours before they die of something like sudden cardiac death. And if we can be smarter about identifying the trajectory of those risk markers, might we be able to apply some sort of multi-marker approach to our patients that is better able to capture dynamic and continuous risk. And I'm happy to talk about that if there are questions about that at the end of the talk. Before leaving this risk transient topic, I also want to just note that continuous monitoring is a part of our lives. We have millions of patients who are currently living with either pacemakers or implantable defibrillators. We have millions of patients who are wearing some component of an Apple Watch or a Fitbit. And so I think we have an incredible opportunity to think about the ways in which continuous monitoring might be able to predict the risk of something like a sudden cardiac death. And I'm happy to expand upon this as well if there are questions from the audience at the end of the talk, but I will move on for the sake of time to the very last set of slides. So how do we now, sort of putting this all together, move beyond our absolute risk paradigm of sudden cardiac death? And so what I'll point out is that the reality that we are living in is a low absolute risk world. These are data from John McMurray and colleagues published in the New England Journal that asked a very simple question: what are the rates of sudden death in big heart failure trials over the last 20 years? And as we commented on earlier, we've gotten better at taking care of heart failure patients. So the reality is that in 2010 and now 2021, the absolute rates of dying of sudden death for our patients are just much, 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 much lower than they were 10 or 20 years ago. And so if we're thinking and focusing only on absolute risk, what I would propose is that that's not going to be a particularly effective strategy to think about who's going to benefit from something like an ICD. So how might you practically identify patients who stand to benefit? Well, one way would be to think about cross-tabulating absolute risk and proportional risk. So in concert with my colleague, Wayne Levy, we performed this analysis in a paper that was published last year, where we looked at a large trial of patients, the SCUD-HEF trial. So this is a randomized trial of an ICD versus no ICD in patients with heart failure. And we looked at absolute rates of sudden death and absolute rates of competing death. And we also looked at absolute rates of sudden death and the proportional risk of sudden death. So Wayne has derived a proportional risk model that actually gives you a mathematical number that says your proportional risk of dying of sudden death is X. And so if you look at quartiles of proportional risk, so highest proportional risk in blue, lowest proportional risk in purple, we then look to see what was the impact of the ICD on all-cause mortality. And so if you focus on this black line, everybody who lives on this black line has the same absolute risk of dying of sudden death, as shown here at sort of approximately 15%. What you'll appreciate, though, is that based on your proportional risk, at the same exact absolute risk, based on your proportional risk, the ICD was either not helpful or wildly helpful. And so what we would propose is that proportional risk serves as a sort of rheostat that helps you dial down or dial up whether or not something like an ICD could be helpful. And so what I would offer is that I think as we're sort of thinking about moving beyond this absolute risk paradigm, we need to be able to provide folks at the bedside proportional risk tools that can be incorporated into conversations at the bedside. So we say, listen, your absolute risk of dying of sudden death is 10 to 15% over 4 years. However, your proportional risk of dying of sudden death is very low. And so for that reason, we think that you're not going to derive a survival benefit from something like an ICD. I think having these tools at the bedside can be incredibly helpful, both for patients as well as for folks caring for patients. This is my last slide, or next to last slide. And I just wanted to share with you some very exciting work going on, predominantly sort of across the ocean, if you will. But all of this work in competing risk and sort of multimodality sort of risk prediction has now come to a head under this large effort known as PROFID. It's a large effort sponsored by the European Union. who's investing more than $20 million in collating in a multi-center, multinational way more than 1 million patients who have coronary artery disease. And the cohort that I've been very closely involved with, Predetermine, is involved in this effort, and it's actually one of the validation data sets in this PROPHET effort. And the goals of PROPHET is to be able to explicitly use these concepts of competing risk, proportional risk, as well as large data approaches, and incorporating sort of standard risk markers, but also a lot of these novel markers that we've been talking about, the 12-lead EKG, biomarkers, cardiac imaging, gene scores, and be able to take all of those things, explicitly take into account the concept of competing risk, and generate a risk model that is specific to the risk of dying of sudden death. And that work is currently happening at the University of Oxford and should be done by the end of this calendar year. Next year, in 2022, that risk tool is going to be used as inclusion criteria for 2 large randomized controlled trials, one in patients with an EF that's low, and the other in patients with an EF greater than 35%. And we'll know, hopefully in 4 years, whether or not this kind of approach is able to personalize our ability to target the ICD to patients who truly stand most to benefit. And so I'd say stay tuned. I'm happy to come back in 5 years and share with you the results of the PROPHET study. But in closing, just to return to the outline of the talk, I hope I've convinced you that our current contemporary approach to risk stratification has major constraints in terms of its application to the risk of sudden death. It's static and cross-sectional. It's not particularly flexible in terms of accounting for transient risk. The ways in which we currently stratify risk are generally dichotomous, and we know that that's not particularly helpful. And at the moment, we are exclusively focused on absolute risk, which I've convinced you is important, but not the whole story. I also hope I've convinced you that competing risk matters, and in particular, that the risk of dying of sudden death is strongly correlated with the risk of dying of other kinds of death. And as an extension of that idea, also hopefully shown you that most of what we have today, be it diabetes or AFib, heart failure, left ventricular ejection fraction, most of those markers are not particularly helpful at sort of disentangling one death type from the other. And that correlated risk has major implications for how we think about the output of our cardiovascular outcomes trials. And hopefully at the end of this talk, I've left you with some sense of optimism that we hopefully are going to be able to advance the paradigm of the prediction and prevention of sudden cardiac death. In particular, finding markers that are specific to the pathophysiology of sudden death, finding strategies including the role of continuous monitoring to capture transients of risk, and then finally at the bedside and in the context of clinical trials, personalizing the approach to risk prediction, explicitly incorporating concepts of competing and proportional risk to truly identify patients who most stand to benefit from our targeted strategies of cardiac prevention. And with that, I will close by just saying a big thank you to lots of folks. Doing work like this is only possible because of the support and sort of mentorship of a lot of people. I want to explicitly thank and acknowledge a whole host of folks here at the University of Washington, including Dr. Poole, who's the chief of our section, Dr. Robinson, who's my senior partner in the complex ablation program, Drs. Stempi and Otero and Levy in the heart failure group. I also want to offer a special thanks to Drs. Ray and Sotudenia, who have been so gracious with their time and has served as primary sort of mentors of mine. And also thank Drs. Stout and McClellan for hiring me and for supporting my work here. And finally, also thank my colleagues sort of around the country at the Brigham and Mass General, at Cedars-Sinai and UCLA, who have all served as close friends and collaborators to make work like this possible. And with that, I will say thank you and happy to answer any questions.
Well, thank you so much. That was such a an amazing talk on a lot of topics within sudden cardiac death, but also just a broadly applicable concept of competing risk. So so interesting to learn about how new ways of looking at this can help. We don't have a lot of time. We've kind of run over here for questions, but I think one question that came in was sort of, given that age tends to be such a marker of competing death and all these sorts of things, how have potentially any strategies focused on anti-aging been utilized in the direct and targeted treatment or prevention of sudden cardiac death?
It's a fantastic question. The holy grail, of course, is sort of anti-aging strategies. There's been some intriguing work. Dr. Albert from UCSF came up and gave Cardiology Grand Rounds a few months ago and highlighted some of the work that her group has done looking at telomere length, for example, and cardiovascular risk. There have been a few studies that I'm aware of that have specifically looked at that concept of telomere shortening and the risk of sort of sudden cardiac death. And I guess what I would say, apropos of our sort of discussion of competing risk, the ways in which I see those anti-aging strategies sort of manifesting practically is in really sort of shrinking competing mortality, right? So I don't necessarily have a sense that those anti-aging strategies will necessarily modify or attenuate or sort of enrich the risk of dying of a sort of sudden cardiac death event. But importantly, if we can find strategies that lower the risk of competing mortality, the mathematical consequence of that is that the proportional risk of sudden death goes up, right? So we saw that in young folks, while their absolute risk of dying of anything is low, proportionally half of that risk is the risk of dying of sudden death. And so I think it's a great question and an incredibly important endeavor. I've been focusing mainly as an electrical cardiologist on risk markers to enrich for sudden death, but you could imagine a whole sort of paradigm of strategies only focused on trying to shrink competing risk, right? So it's trying to shrink heart failure mortality, trying to shrink sort of the risk of dying of other things, and sort of as a consequence of that, inflating proportional risk, and that would accomplish the exact same goal. So I think it's a fantastic question and an exciting avenue for investigation.
Yeah, and along those lines, I had seen sort of recent work looking at ARNI therapy and the reduction that had on sudden cardiac death. It sounds like sort of teasing apart the two populations, one who has a syndrome of heart failure that may manifest as sudden cardiac death amongst many other causes of death. And it's reassuring to see the treatment of that proximal cause seems to have an impact. So really trying to capture this enriched population of isolated cardiac death, specifically when you're talking about a therapy like an implantable cardiac defibrillator that's really only targeting one cause of death. Super interesting work. Thank you so much for this talk. I personally learned a ton. Thanks everyone who tuned in, and that concludes this week's Grand Rounds. Have a great weekend, everyone. Rest of your Friday afternoon.
All right. Thanks, everyone.